Good afternoon. My name is Brooke Lerner, and I'm with the Medical College of Wisconsin. The purpose of this talk today is to understand the SALT mass casualty triage method, which will be incorporated into the Milwaukee County mass casualty protocols. Also, we will spend a short amount of time practicing the SALT triage method. As you probably know, triage comes from a French verb meaning to sort. It's essentially assigning priority to patients when resources are limited. That is, when there are more patients than there are responders. It's unfortunate but true that someone needs to be treated first and someone will have to be treated last. And the overall goal is that we do the greatest good for the greatest number of people. Essentially, our resources are overwhelmed, and all we can do, rather than our typical day-to-day of doing the greatest good for each person, is do the greatest good for as many people as we possibly can. Many times when we learn and practice our mass casualty triage methods, they look something like this picture, where people are lined up, following directions, doing exactly what they're told. Things are neat and very orderly. However, when you see an actual event, it probably looks a little bit more like the next picture. This picture shows the Virginia Tech incident where we have many responders. There's still some security issues. Patients are being carried. Things are a bit more chaotic. This picture shows a earthquake in the Middle East where we've had a structural collapse. You can see that there's bystanders in the structure, a lot of hazards, much less organized than the initial picture of practicing triage. This picture again shows the chaotic nature of these scenes. It's not nearly as organized as what we typically practice. And what a responder needs to remember is that these scenes are going to be chaotic. People are going to be everywhere looking for different things. And that along with the medical care that we're trying to sort and make sure the right person gets the right thing, we're also dealing with human nature and a human need to find loved ones, relatives, friends, as well as to get themselves away from danger. And so this process really is about the provider trying to bring some type of order to this very chaotic environment simply through their words and actions. The concept of mass casualty triage was first described during Napoleon's time when his surgeon-in-chief developed ways of selecting casualties from the battlefield who needed immediate assistance and trying to get as many back onto the battlefield as possible. 200 years later, we have dozens of types of triage systems and many triage labeling tools. Further, there is no standardization for mass casualty triage across the United States. This means that agencies that could be next to each other may not use the same system. They might not use the same words, the same color codes, or the same process for categorizing people. This isn't an issue when these agencies are responding independently, but during a large-scale mass casualty event, it may cause them not to be able to respond together or to be interoperable. SALT triage was developed as part of a CDC-sponsored project that was intended to develop a national standard for mass casualty triage. This was based upon visits that they had to other communities that sustained numerous terrorist events, in particular a visit to Israel, where the Israeli responders said that one of the problems within the United States is that we do not have standardization for our mass casualty triage process. SALT stands for Sort, Assess, Life-Saving Interventions, Treatment, and or Transport. And it's based upon the best available evidence that's in the scientific literature today. The concept of developing a national standard for mass casualty triage has been endorsed by the American College of Emergency Physicians, the American College of Surgeons Committee on Trauma, the American Trauma Society, the National Association of EMS Physicians, the National Disaster Life Support Education Consortium, and the State and Territorial Injury Prevention Directors Associations. So this concept comes strongly supported by national emergency medical services organizations. This slide illustrates the SALT triage method. We will now move step by step through the method, explaining how it is used. The first step is a global sorting of patients. It's represented here in the SALT triage method. The first step of global sorting is to use your voice to begin to separate patients. So the first thing you'll say is, "Everyone who can hear my voice, please move to this designated area and we will help you." If possible, using a loudspeaker, but otherwise repeating this statement as you move through the crowd. The goal of this step is to have ambulatory patients, or those patients who are healthy enough and have sufficient oxygen to their brain and able to use their limbs to be able to follow a command and move to a designated place. These people, who are essentially the healthiest, will be the last priority for individual assessment. Next, you will say, if you need help, please wave your arm or move your leg, and we will be there to help you in just a few minutes. This statement will allow you to identify those non-ambulatory patients who have sufficient oxygenation to be able to follow your commands or make purposeful movements. The result is that these people who are able to wave or move their leg will become your second priority for individual assessment. Once you've completed making these two statements, your casualties are now prioritized for who you should go to first for individual assessment. Your first priority are those people who are still, or those who have obvious life threats like an extreme extenuating hemorrhage. Your second priority are those people who are waving or making purposeful movements. And your third priority are those people who are able to walk away. Now, clearly, there are some issues with this in that a mother who has a small child may pick up their child and walk away even though their child couldn't have gotten there on their own. And this is why this isn't the final triage for any of these patients. It just is an initial way to get things organized and decide who to approach first to assign a category. The other issue would be that some people, say a husband and a wife, where the husband is unconscious but the wife is able to walk, may not be willing to leave her husband, and so thus may stay in the area where your first and second priority are, even though she probably is more of third priority. So this method isn't intended to be 100% correct at this point, but to get people organized so that you can quickly move through those who are the most likely to need life-saving interventions before moving on to other patients. The next step is to individually assess each of the patients that's in front of you. And the first part of that assessment is to determine and provide any life-saving interventions. So when we look at the scheme, we're talking about this section right here. Does the patient need life-saving intervention? Life-saving interventions include controlling major hemorrhage, opening the airway if the patient is not breathing. However, if that patient is a child, you may give them 2 rescue breaths, providing chest needle decompression, or giving auto-injector antidotes if there is a chemical exposure. These interventions should only be provided if they are in the realm of your training, if you immediately have the equipment available, and if they will be able to be provided quickly and allow you to then move to the next patient. You would not want to provide, say, intubation to a patient whose airway was not open and then commit yourself to providing artificial respirations for that patient. You simply want to do a basic head tilt chin lift to open the airway, and the patient would need to maintain that airway on their own. You may also insert an oropharyngeal airway if you happen to have one in your pocket or on you. You would not walk back to the rig and get it and then come back and provide that intervention. You want to do these things quickly and continue to move on to the next patient. The next step is to actually assign a triage category to these patients, and that's this section here of the algorithm. The triage categories, like the triage system you may currently be familiar with, include immediate, delayed, minimal, expectant, and dead. Expectant may be a new category to your system. The first thing to determine is whether or not the patient is dead. And unlike when there's only one patient and multiple responders, a patient is considered to be dead if they are not breathing after one attempt to open the airway. If the patient is a child, you can consider giving them 2 rescue breaths, since it is well documented that child cardiac arrests typically start with a respiratory arrest. However, if the child is still not breathing, they must be tagged as dead. Once you have selected a patient and identified that they are deceased, you must place a tag on that patient. This will help next providers to see that that patient has been evaluated and triaged and move on to next patients, rather than wasting time continually reevaluating this patient. Also, keep in mind that you will not want to move these patients for law enforcement reasons, because essentially you want to preserve evidence as much as you can. The only exception to this is if you need to move that patient to obtain access to another live patient. Then it is completely acceptable to move that patient. If the patient is breathing, then you want to conduct the next assessment. The next step is to determine if the patient is an immediate patient, which is designated with the color red. These patients have serious injuries that are immediately life-threatening, but have a high potential for survival. Examples include tension pneumothorax, exposure to nerve agent gases, which results in severe shortness of breath or seizures. In determining if a patient is immediate, you essentially determine the answer to the 4 listed questions. A no to any of these questions would result in considering making this patient immediate. First, you would determine if the patient has a peripheral pulse present. That is, do you feel a pulse? Next, you would determine if the patient is in respiratory distress. If they have a hemorrhage which is uncontrolled, or if they're able to follow commands, or if they can't hear or are too young, do they make purposeful movements? Again, carefully read these questions, and a no to any one of them would result in considering a patient to be immediate. If that is the case, then the next question you need to consider is whether this patient is likely to survive given the available resources. A patient who is unlikely to survive given the available resources is considered expectant and designated with the color gray. An expectant patient is someone who is, again, unlikely to survive given your available resources. It's important to remember that this does not mean the patient is dead. It is a way to preserve your resources by providing care to people who are likely to survive and postponing care for those who are unlikely to survive. However, these patients do deserve care when the resources are available. They should be provided with comfort care or attempted resuscitation if you have the needed resources. These people have serious injuries that have a very poor likelihood of survival, even if they were to be given the maximal care in a hospital or the pre-hospital setting. Examples would include a patient with a body surface area burned to 90% of their body, or someone with multiple trauma that has exposed brain matter. These patients, even in the best of circumstances, if they were the only patient on the scene, are highly likely to die, and therefore resources should probably be first devoted to those people who are more likely to survive when they are limited than to be given to these patients. The next category of patients is delayed, which is designated with the color yellow. These patients have serious injuries that require care, but their management can be delayed without increasing the patient's morbidity or mortality. Examples are long bone fractures or small body surface area exposures to mustard gas. If you look at this picture, this is a patient who could wait a little while for care. However, they're not going to walk away and go days without care. They need care eventually, but not right away, not as quickly as someone with, say, a tension pneumothorax. The next category of patients are delayed patients, which is designated with the color yellow. For these patients, you would ask yourself those same 4 questions, but the answer to all of them would be yes. That is, the patient would have a palpable peripheral pulse, or a pulse that you could feel at their wrist. They would not be in respiratory distress. Their hemorrhages would be controlled. They would be able to follow commands or make purposeful movements. Once you have a yes to all these questions, you would then evaluate the injury and decide whether or not they are minor. Patients who are designated delayed have injuries that require care and thus are not minor. Also consider, when you think about hemorrhage, if you are faced with a patient who had an uncontrolled hemorrhage and you applied a tourniquet to that injury and the bleeding stopped, these patients would become delayed because they would not have uncontrolled hemorrhage, and thus their care could be slightly delayed, although they would still need care. The final category is minimal, which is designated with the color green. Like delayed patients, you would answer these 4 questions yes, but when you looked at their injuries, they would be minor. Examples of minimal patients would be patients who have very minor injuries that require little or no care. For example, abrasions, minor lacerations, a nerve agent exposure with a very mild runny nose. These patients have small injuries, but these injuries could wait a very long time for care, hours, days. And so they should be prioritized last, given that your resources are limited at that point. Once you've placed a patient in a category, it's important to remember that this process is dynamic. That is, patients' conditions can change at any point. They can get better, they can get worse. Also, we know from experience with drills and other events that as time goes on, our decision-making gets better. And so you may come through and fix misses or correct things. Also, resources change. More people will come to the scene. Your resources won't be as limited, and you'll be able to get care to people you've prioritized as going last or later in the response. Now we will practice the SALT triage method. Imagine yourself responding to a multiple gunshot wounds at a local sporting event. You and your partner are the first ambulance in. There's only the two of you at the scene. There are 8 casualties. You've been told that the scene is safe and additional assistance has been requested for you. What should you do first? As we discussed previously, your first step would be to globally sort these patients using your 2 voice commands. If you can hear my voice, please move to this area. And if you need help, please wave your hand and I will come to you as soon as possible. You call out your commands and ask those who can walk to a designated area. You then ask those who can wave to wave and tell them that you'll be right there to help them. As you look across the scene, you see that 2 patients have walked to your designated area. 3 patients have waved, and 3 patients are still. Which patients will you approach first to conduct individual assessment? The first patients you should approach are those who are still. There are 3 patients who are lying still. The first is a 29-year-old male with a gunshot wound to the left chest. Radial pulses are present. He has severe respiratory distress. How would you triage this patient? This patient is immediate. The next patient is an 8-year-old female. She has a gunshot wound to her head that's through and through. There is visible brain matter and her respiratory rate is 4. She does have a radial pulse present. How would you triage this patient? This patient would be triaged as expected because there is a poor likelihood of survival given that the gunshot wound is through and through and you can see brain matter. The next patient is a 50-year-old male with a gunshot wound to the abdomen, chest, and extremity. There is no movement and he is not breathing. How would you triage this patient? This patient would be triaged as dead because he is not breathing. You next move to the patients who are waving. There are 3 of those patients. The first is a 14-year-old male. He has a gunshot wound to the right upper extremity. Active, massive hemorrhage, good pulses. What would you do first for this patient? If you said apply a tourniquet, and you do that, you would find that the bleeding has stopped. Once the bleeding has stopped, how would you triage this patient? What category would you assign? This patient would be considered delayed because he no longer has uncontrolled hemorrhage. Therefore, he would be placed in the delayed category. Your next patient is a 65-year-old male with severe chest pain. He's sweating, obviously in respiratory distress, but has no obvious gunshot wound. How would you triage this patient? This patient should be triaged as immediate. Clearly, this patient was not shot during the incident. However, he is likely to be having a myocardial infarction or a heart attack, and thus he should receive immediate care to increase his likelihood of survival. Therefore, this patient would be triaged as immediate. The next patient is a 22-year-old female with a gunshot wound to the right lower extremities. She has good pulses, no active bleeding. How would you triage this patient? This patient should be triaged as delayed. Clearly, this patient needs care. However, she has pulses, no active bleeding, no respiratory distress, and she's able to follow commands because she's waving. Next, you approach the patients who have walked away. The first is a 29-year-old male with a superficial gunshot wound to the skin of the left upper extremity. So this is a minor scratch to his arm. How would you triage this patient? This patient should be triaged as minimal because he could wait to receive care. The next patient is a 37-year-old male with a gunshot wound to the left hand. He has exposed muscle and tendon and bone fragments, and a peripheral pulse is present. How would you triage this patient? This patient should be triaged as delayed. While this is probably not a life-threatening injury, this patient will need care to ensure his future use of his hand. Therefore, he should receive care ahead of the patient with the superficial gunshot wound, and therefore, his injuries are not considered minimal, and he should be categorized as delayed. All of your patients have now been categorized, and you must consider what to do next. So far, another ambulance has arrived and transported 2 of your immediate patients. Your partner is providing care to the other immediate patients. What will you do next? Next, you will reassess your patients to ensure that people have been appropriately categorized and you haven't missed anything in the first time around. You will consider whether you have time to provide any comfort care to the patient you have labeled as expectant. And you will verify that none of the other patients have decompensated or gotten better as time has gone past. You have now learned and practiced the SALT triage method. This method has 2 steps. The first is to globally sort patients through voice commands, and the second is to conduct individual assessments, which includes providing life-saving interventions and then assigning a triage category or providing patients for treatment and or transport. That concludes this lecture. Thank you for your attention, and again, here is the SALT triage method.